I'm Hannah. I'm a little bit of an intruder here because I'm a PhD student just listening in. I live in Canterbury. I live in Canterbury and I've got a different motive. I'm just learning kind of about treating autism as opposed to exams.
Okay, thanks.
Hello, I'm Danny. I manage a support living service in Gatwick. I'm second year autism part-time, and from this I'd like to know more about autism because you can never really know enough.
That's true.
I'm Jenny. I'm a behaviour advisor for social care. I want the exam answers really.
No problem.
Thank you.
Good. Okay. Well, I'm Richard, and you've got me for the morning. We've got quite a lot of stuff which I'm told we have to get through, but I'm going to try to whiz through things that I think that you've probably covered anyway. But if we haven't, then just say we haven't covered that, and we can go back and revisit some of these things. But it's your session, really. That's the point. So there's no point me sitting here talking at you if it's not hitting the spot. So it's really up to you to ask questions. I think that's part of the deal. Now I'm going to hand the handouts, and there's another deal here that you don't get to the end before I. Okay? That's very important. So this is just for you to scribble on, make notes. But if I see anybody getting ahead of me, I shall get really upset and anxious. And meltdown, whatever it is you do. And is everybody signed in? No. You haven't signed in. Yeah. So wherever the sheet is, could it be passed around? Is the signing in sheet with you guys? Excellent. Thank you. So the title of my talk today, and I spent quite a lot of time working for the National Autistic Society, 22 years. I know I don't look old enough, but 22 years of my life was spent working for the NAS. Firstly, looking after the schools and the adult services, and running some of the clinical services and the early bird programme and supported employment. And then for the last 10 years that I was with the NAS, I was heading up the research section there. So I went from very hands-on practical stuff, really, in admin and bureaucracy, into the research area. And since January, I've been more or less full-time working for Research Autism. And I no longer work full-time for the NAS, but I still do a lot of projects for the NAS, including leading an EU project on the needs of women, autistic women, which is an under-researched area. This talk was first given last year, and I'm going to update it as we go, because I didn't want to give Jill a nervous breakdown by changing it at the last minute. So I will amend it as we go along, because there is some new stuff. The picture is constantly evolving. So that's the deal for today. Okay. So what are the key questions then? I think that people tend to know, is there a cure for autism? These are the things that you hear. The Daily Mail and august newspapers like the Mail will throw these things out from time to time. Is there a cure? Can you prevent autism from happening in the first place? And a lot of research goes into both of these areas. If you go to IMFA, the International Meeting for Autism Research, you will see lots and lots of papers on these two topics. Less interest in the third one, is autism treatable? And then what are the best treatments for autism? Because if you're a parent, these are questions which are very important to you, I suspect. And we're going to come back to these in a minute. That's the sort of general framework for the talk today. So, the Lancet says we don't really know what autism is. That's a good start. We don't really know what autism is. Should we be talking about the autisms rather than autism? There's probably more than one condition that we call autism. And should the research be in the areas of looking for subtypes that can be defined? And certainly a lot of the research is about identifying genotypes where there are specific syndromes associated with autism which might be susceptible to particular treatments. So, do you know this gentleman? This is Will Rogers. Will Rogers, a Hollywood film star. And he said, it ain't so much the things I don't know that get me into trouble, it's the things I know that ain't so. And I'd like you to sort of just hold that in your mind about autism, because we've made so many mistakes in the years about fundamental misunderstandings about what autism is and what it is not. And facts about autism turn out later not to be facts at all, because they are disproven in the light of further research. So when people say, oh, and that's a fact, I would just be a little bit cautious about that. So remember Will Rogers. It ain't so much the things I don't know that get me into trouble, it's the things I know that ain't so. You know, and we've had lots of these in autism about early intervention, for example. Early intervention is critical in autism, isn't it? We all know that. Yes? Agreed? Fact? No, it isn't a fact at all. It's somebody's opinion which is repeated lots and lots and lots of times so that it becomes a fact. But there is no evidence at all for that statement, that early intervention really is the big deal that it's sometimes made out to be. So, you know, just let's be a little bit cautious. I'm not saying it's a bad thing, but it isn't a big deal. Parents are bombarded with information, and we have this thing now, this wonderful invention called the internet. And so you don't have to rely on professionals anymore, you can go to a computer and everything is there. But as T.S. Eliot, who, as you all know, because you're all very highly educated people and you're in Canterbury, who wrote Murder in the Cathedral, T.S. Eliot, where is the wisdom we've lost in knowledge and where is the knowledge that we've lost in information? And I think that this is very, very true of the internet. And if you look, this one is out of date now. I've got a more up-to-date one, which is if you hit the button around autism, 1.5 million hits. I think it's up to 19 million now. A year later, you get 19 million results for autism. So you know, lots and lots of information. If you're a parent with a child who's just had a diagnosis of autism, what are you going to do? Trying to sort this out. So, what are some of the key points? We know that the rates of autism, certainly in the United States and in the UK, are rising. We don't know why that is. We've got various theories as to why that might be. Is it better recognition? Is it a real increase? We don't really know. Other parts of the world don't seem to have the same rate of increase. Certain parts of the United States have a lower increase than others. Why is that? Why do you think that is? I'm asking the question.
Is it because of Asperger's? Before Asperger's wasn't recognised as much, and now it is. It means that more people are falling to the spectrum than before.
That's one possible explanation. It doesn't explain the different state to state. I think that it certainly explains why rates have increased. That Asperger's syndrome wasn't, or high functioning autism stroke Asperger's syndrome wasn't recognised until much later. And there is an increase that ties in there. But the main reason, it would seem, is the number of clinics diagnosing autism. So you could say that clinics cause autism, which is a stupid thing to say, but that's, you know, a sociological perspective would say, if you've got lots of clinics, then you've got better awareness, so you're going to diagnose more cases. So it's an artifact of the diagnostic process, as well as I suspect you have, where you have lots of clinics, you get lots of false positives as well. They're not all true cases. And a lot of cases that were diagnosed as autism, probably not diagnosed in certain parts of the world. Increased numbers of treatment. Lots of treatments, explosion of treatments. If you go to the Research Autism website, you will see just how many of these things are out there. You know, and it's quite mind-bending, you know, the number of different treatments that are there. But vulnerability based on ignorance and misunderstanding. Ignorance about autism is misunderstanding of the nature of autism. I'm going to talk a little bit about that in a minute. And most of these treatments that are out there is a very poor evidence base. Remember that. When people start talking about facts about particular interventions, the evidence base that they're coming from is very low. And I sit on a couple of nice committees. I was on the Autism Committee for Adults, and we were looking at the strength of evidence in support of different treatments. And we couldn't find anything, with the exception of one paper, that met the standard for quality research. And that was a paper by Patricia Howlin on supported employment. That was the only one that crossed the threshold from being interesting to, yeah, this is pretty solid stuff. So, you know, evidence-based is pretty poor. And self-advocacy has also been a huge deal. Autistic people speaking up for themselves made the biggest single contribution, I think, in the past decade to autism research. Rather than being passive recipients and subjects, you now have people like Michelle Dawson being one of the more well-known people who is an autistic researcher who is incredibly able and just a superb critic of papers and research. So, what is autism? Now, you know all this stuff. I'm going through it very, very quickly. It's to do with the brain. It's not to do with the way that children are brought up. We seem to see more males than females, but that might be an artifact of the diagnostic process. Lots of causes of autism, huge diversity. Heterogeneity is another way of saying we don't even know what it is. Comorbidities are highly significant. And with those comorbidities, we're talking about things like stress and anxiety, which accentuate the symptoms of autism. Neurological problems, mental health, sensory processing problems. It wasn't until relatively recently that people started to pay attention to these sensory processing differences. But remember, and again, this is a fairly well-known fact, but until recently hasn't been taken account of, there are strengths as well as deficits in autism. What do they look like? Well, you can see from the brain, I can talk a little bit about the nature of autistic intelligence, because I think this is important for us when we're thinking about intervention. These are functional magnetic resonance images of parts of the brain depicting the perceptual regions of the brain which become more active in autistic subjects than non-autistic subjects. So there is something we know that happens within the brain when people are asked to perform certain tasks. The shorthand of this is to say that it's not that autistic individuals lack empathy, but they might get to the empathy ending through a different route, through an intellectual rather than an emotional route. Is one of the hypotheses that's allowed. But going another way, if you look at this, do you know what this is? The mean subtest scores of 38 children on the what they call the WISC. Are you familiar with the WISC, the Wechsler test for children? And I think you will see this as a pretty typical WISC result. Yes? In that block design is a strength. These children tend to be very, very good at block design. You know, how to arrange patterns, attention to detail, see something, make sense of it. Visual, highly visual, yes? But in terms of comprehension, they score very badly on the WISC. So you could say, is the WISC a good test for autistic children? Knowing that children are going to struggle with comprehension anyway. Sorry, go back. Okay. If you look at, this is one of the glitch that's occurred, I shall have to draw attention to Jill's attention to. But if you compare using another test called the Raven's matrices. Are you familiar with Raven's matrices? They're an autistic friendly IQ test. It tells you how bright somebody with autism is, basically. It wasn't designed for that, but that's what it does. And if you see here, autistic children versus controls on the different areas, on the different tests, you'll see from the WISC, they score pretty badly, yes? These children score. If you use an autism-friendly test, like the Ravens, which makes sense, that they can make sense of, and I'll show you what a Ravens looks like in a minute, then they do a lot better. Not quite as good as controls, but better, yes? But as adults, and this is the interesting thing, autistic adults continue to perform poorly on the Wechsler tests, but they outperform controls on the Ravens. So what does that tell us? That confirms, really, scientifically, that autistic adults have a different kind of intelligence. It's not a lower intelligence or a lesser intelligence, it's a different kind of intelligence. Which is why you see so many people in those sciences which require those kind of skills. The development of technology being one of them. Does that make sense? Are you all with that? Because I'm going to test you now. Okay, this is Ravens. Very, very briefly. We'll keep on top of the time. Which is the missing one? Which one? 4. You all happy with that? So you get the hang of it. Okay. That's the easy one. Which is, and this one over here. 6. Agree with that? And the next one? Number 1, yeah. And this one? Come on, quick. Quicker. 5, yeah. And the next one? Nice. I think so. And the next one? Yeah, it's easy, isn't it? Very easy. Okay. Well, when you see, I tell you, when you see autistic adults sailing through these in half the time, then that tells you actually, you know. So, okay. If you look at, again, looking at the WISC, along the bottom, you will see people pretty poorly performing. The Ravens, the number of autistic subjects up near the 100% is up there compared to controls. Controls all over the place.
That's just, is that like a range of different things that you're testing? Because that's quite a specific skill, isn't it?
Well, yes, it is, yeah. People get written off because they have the wrong tests. I feel very, very strongly about this. I've seen people, you know, being given a WACE or a WISC, and people come to conclusions about their level of intelligence and functioning on the basis of tests which are unsuited to them. It would be like me examining you in Russian and expecting, you know, your exam questions being in Russian. You don't answer any of them, so I conclude from that you're pretty dim. You know, it really is as crass as that. So I feel very, very strongly that we've got to get the right tools. Before we start wading in with our various interventions, we need to get to know who these children are and who these adults are that we're working with. So we need to spend a lot more time understanding them and assessing them. So, okay. Well, you know all this. The autism, we know that it's present from birth or very early life, and some very nice little Renoir paintings which show this thing called joint attention, which underpins most of the concerns that parents have. But as Kathy Lord says, it's really to do with the presence of the unusual, but much more to the absence of the usual. So it's not so much about spotting positive signs of autism. We need to be very vigilant about spotting those things which should be there but are not there. And medical assessments have not been terribly good at that in the past. Medical-based assessments are less good at spotting these absence of the usual. They're looking for classic signs of disease or disorder. So the social instinct, as Lorna Wing calls it, is impaired. Then there are a whole range of overlapping conditions which are not autism, but can affect autism, affect outcome, and affect behaviour, which we've spoken about. But we can't separate these things from the environment in which the person lives and the relationships that they develop. And if you talk to autistic adults, and I spend a lot of my time talking to autistic adults, they will point to a key person in their lives that's acted as an anchor or a mentor, someone whom they can have a relationship with, who they feel safe with. So as a means of developing self-confidence, self-esteem and so on. So again, before we go racing up into intervention, I think we need to consider the environment in which this person lives and the relationships that they have. Because we know, again, from if you look at the scandals that have occurred in places like Winterbourne View, the quality of relationships and the quality of environment was incredibly poor, and yet people were still treated for their behaviours. Well, I don't know how any of you would behave if you were separated from your family, communicated in a way where you were fearful, given nothing to do all day, but I dare say it would impact on your behaviour in some way, and then you'd be given a lot of medication, obviously. So, you know, we need to be very mindful of the environment and relationships that we are in. Oops. So, secondary symptoms of autism that we talk about, real mixed bag of stuff. These are mainly negative things, yeah, literal poor, anxiety. But how much of that is a breakdown in mutuality? We often accuse autistic people of lacking empathy, whereas we clearly don't see the world terribly well from their point of view. So I'm putting these up there because I have to really, in a sense, because that's what people talk about. But I would invite you to think about mutuality here and your role in this, and your role in reducing some of these things, which are seen as the negative secondary symptoms of autism. So, but families, again, the issues for them, they get to know, they think that something is wrong with the child, the way the child is developing. Probably not any more definite than that. Then they have this struggle of getting a diagnosis and all that entails, getting people to listen to them, take any notice of them. Then there's the coping with the diagnosis, and that can often be given in a way which is incredibly negative for families, or it can be given in a positive way. Then fight for support, treatments. Having a child with autism in the family, for some families, not for all of them, can be incredibly stressful and demanding. And I think that if you are engaged with families, working with children, it's not all about you, and sometimes therapists think it is. And they're getting involved with, certainly with the intensive behavioural treatments. And families have got a lot of other things to cope with and deal with it as well. And there was an excellent randomised controlled trial conducted by David Mansell and colleagues last year, looking at treatment fidelity on behavioural treatments. And what Mansell et al. Concluded, which is something that we've known all the time, and that's the beauty of really well-designed trials, is that things that work in the lab under controlled research conditions don't actually work in the real world. Yeah, and that was, demonstrably present in that trial. That, and even in the lab conditions, it wasn't great. But the treatment fidelity, that is, the adherence to the method outside of the lab, fell away. And it's Mandel. I can, if you send me an email, I'll send you the paper, okay? Because it's such a good paper. And it raises a lot of very important issues about why there should be. And a lot of it is to do with the stress that families are under, the stress that staff working in schools are under. You know, with all of these inspectors cruelly on every 5 minutes, those kind of things. So, very impactful. Actually, just having a child in the family is going to affect a lot of things. Thomas Gualtieri, a psychiatrist, a friend of Lorna Wing's, talks about assumptions about the nature of autism have always influenced and will always influence approaches to treatment and outcome. That is, it's almost a self-fulfilling prophecy. If you think the Earth is flat, then you're convinced you're going to sail off the edge of the planet. This is sort of the theory. So, the current position then, as I've said, there's very poor evidence overall. There's been very little research, and we've just published a major research document called A Future Made Together. Have you come across this? Make a note of it. I'll send you the link. Future Made Together, looking at the status of autism research across the world, particularly in the UK. Lots of different treatments in use. Lots of interest in biomedical approaches, you know, these diets and all that sort of stuff, but there's not much evidence that any of them work. Psychoeducational approaches, that is, some of the behavioural approaches, are widely used and abused, as we know. And lots of claims that are made for these things which don't actually stack up when you actually read the papers. And I read lots and lots of papers, one of the things that I do. But when you actually look at the claims and then hit the evidence for those claims, there isn't a joining up in the middle. Structured behavioural approaches do seem to be helpful to some people. You know, division teach and all that kind of stuff, and the spell stuff that we're going to be talking about later. Again, the drugs are widely used and abused. There's no drug for autism, as we know. Aggressive marketing of some of these approaches, and parents are bombarded with this stuff again. You know, that they're made to feel terribly guilty. They don't carry out this latest treatment. And a lot of these claims are completely misleading. And some of them are false, actually. The people themselves don't believe it. You know, they're just trying to make money. So, you know, and it is, the healthcare fraud is big business. And parents of autistic children are among their targets. So we have to be mindful about that. So, linking causes to intervention. Oops, sorry. So what are we aiming to do here? You know, are we trying to cure autism? Reduce the disabling effects of autism? What are we trying to do? Treat other conditions which can be treated, such as epilepsy, such as anxiety. Help students to stay in the classroom. What are we trying to do? What's the aim of the treatment? Because so often, the aim is not clear. And people will put out a program, an autism program, and you ask them, what is this program for? They can't actually tell you. So my advice to parents is always ask what it's for. What does this actually do? Because only if you know what it claims to do, can you then check, has it done that? Yeah? You need to be very, very clear to link the two together. So, we now know how to diagnose autism. Hooray! Well, we think we do, but we've just changed this. You can see this DSM-4 TR, which is the old one that I use, people like me, and ICD-10. Now DSM-4 has now become, as you know, DSM-5, and Asperger's syndrome has dropped away, so we no longer describe Asperger's syndrome in DSM-5, but we're European, so we use ICD-10. We don't bother with DSM-5, that's for Americans and the rest of the world. So there's inherent confusion. But ICD-10 is being revised and will become ICD-11. See, you see a trend here? 10 and 11. It's likely that it will follow many aspects and it will be problematic. Now, a lot of people are very unhappy about these changes because we thought we could diagnose autism reliably. Now we know we can't. So instead of there being 3 domains, there are now 2. Okay? So this is a fundamental problem. The National Institute for Mental Health in the United States, Professor Tom Insel, they are refusing to fund any research based on DSM-5. So that shows the level of confidence within the establishment of this revised. So, diagnosis is possible, but problematic. So we've gone forward a step and back a step at the same time. But we all also remember that everybody's a bit different, one from another, and they all differ. We've had twins that I've known very, very well in our schools, identical twins, who've been very different chaps, and they've responded very differently to the environment in which they're in. One of them was very withdrawn and and non-verbal, and the other one was completely the opposite. This is even within twins. So this, this diversity isn't just about whole populations. Core features of autism, the autism personality, if I can put it that way, we know is highly resistant to any kind of, and because your personalities are highly resistant to change, I would suspect. I venture to ask. You're going to be the same kind of person regardless of what happens to you, and so it is in autism. We need to bear that in mind. So, what should we be looking to target then? Is it autism? Some underlying neurological disorder which causes autism? Possibly. The mechanisms of autism? Possibly. But we don't yet know enough about that. So how can we do that? How can we intervene if we don't know anything about something? The secondary symptoms, the cognitive effect, autism thinking, the way that autistic people think, can we intervene there? Possibly. We can model different behaviours, we can talk to people, we can show different ways of thinking. We can tackle individual specific behaviours, and that's an industry in itself, is it not? The behavioural treatment industry, if I can put it that way, trying to change people from being autistic to non-autistic. Now that again has attracted a lot of criticism from within the autism community as being intolerant of difference. That it's my right to be different if I'm autistic. I have the right to be different. In the same way that if I'm gay, or if I have other different opinions, if I'm from a different part of the world, if the colour of my skin is different, then I'm entitled to be treated with respect in exactly the same way. Why not if I'm autistic? What's the big deal? That's something that we need to, again, be mindful of when we go into some of these heavy-duty behavioural interventions, especially when there isn't a really good evidence base that some of these things work. And we know that there is a negative connotation. And there is a history here that, again, the autism rights people would draw your attention to, that the University of Los Angeles, California, Ivor Lovaas and his group started off behavioural treatments for which group? Do you know?
Early intervention for 2-year-olds.
No, before that. Which group of people were the beneficiaries of Ivor Lovaas's behavioural treatment?
Offenders?
Effeminate children. Effeminate children. Boys who were gay. Turning them from being gay to not gay as a result of very powerful behavioural treatments which involved all manner of aversives, including slapping, which was translated and transferred into the autism program. Very high-duty, high-powered aversive treatments. So again, we need to weigh in the balance, the ethical considerations before we go diving into some of these accepted on face value behavioural treatments. Because the autism community will remind you that acceptance of difference is very, very important. These are a little bit easier in a sense, the comorbid conditions or overlapping conditions. Other neurological disorders could be seizures, so tic disorders, all of these things that seem to be more common if you've got a diagnosis of autism. and need to be picked up and treated. Sensory disorders, we know sensory processing disorders, very different in autism. A whole range of medical problems. Gut problems. Now, at one time, and there's no pun intended here, but people used to poo-poo gut problems as irrelevant. But we now know, because of research, that gut problems are very important. And they tie into anxiety, and they tie into sensory processing. I think that's really neat. Very, very good paper written by Mansell and colleagues, showing a very, very big study, the number of children with these clusters of problems. So that gives us some good information to go on. We can begin to think in terms of gut, sensory, anxiety. Gives us a bit of a foothold on that. But these are not core problems, these are associated problems. Sleep disorders, very, very common. I was sleep deprived. I actually got up this morning to come to this wonderful institution. I got up at 4 a.m. No, actually 10 to 4. So I'm not exactly. If I go to sleep at about midday, you'll know why. So I'm sleep deprived today. If that was to happen to me every day, then I probably would not be able to function at all. I mean, I'll leave it to you to decide whether I'm able to anyway. But these are very important issues in autism. And sleep disturbances in autism are incredibly common and not well treated. Not well treated. The number of parents I know who've got their kids on melatonin that they get their relatives to buy when they're in America, which may be a placebo for the parents, but it doesn't seem to do very much for most of the children. And we know from Emily Simonoff and her group, the number of children with psychiatric disorders is very, very high. Something like 70% of children with autistic disorders also have associated psychiatric problems. So again, these are all things which will impact on autism, impact on outcome, but can be treated. And often they're not treated because there's an overshadow of the diagnosis of autism. These children can be deprived treatments because of their primary diagnosis of autism. And the other thing, the other target is the environment, the family, working within the family. And the number of times I've been asked to see children at school, and I walk into the school and I'm met with this sensory onslaught. And the school cannot understand why this child does everything possible to try to escape from it. And you think, well, you don't actually need to do anything with the child at all, but you need to do quite a lot, actually, with the environment in which this child is, or the way that you relate to the child. So that's another main target for intervention, nothing to do with the child. And again, the number of times I've seen children with behavioural programs who've been in the most unsuitable physical environment, and they say, this is not working. Well, of course it's not working, because it can't work in this environment. You don't need this kind of program if the environment is right. So you need to do nothing with the child, but plenty to the environment. And the way that society also relates to autism. Do we live in an autism-friendly society? I think it's getting better, actually, but there's still an awful long way to go. So in the same way that we have disability access to public buildings, a lot of autistic friends that I have can't go to certain places, again because of the sensory environment, or because it's a terribly confusing place for them to go to. Where people give a lot of verbal instructions. Railway stations, they're typically bad. They cut out all of the announcements. We'd be much happier, wouldn't it? There's nobody, you can't hear them anyway, and they don't make sense usually, and they're contradictory. So why not just stop them? Because I know a lot of people that say we really struggle with that environment. Okay. So on to treatment of autism then. So we talked about these ethical dilemmas. How do we value diversity and at the same time treat people who need some help? It's a costly business, we know that. It costs something like £27 billion a year, the autism bill in the UK. A lot of money to provide bad services. So these are not terribly effective services that are being spent for this. Conceptual problems that we have around cure or recovery, this one keeps coming back and won't go away. But one of the main difficulties that we have is that the approaches that we see are led by the therapist rather than based on the needs of the child. Would you agree with that? Is that a fair comment? Most of the things that you see, how many of them, are really based on what the child needs. Not many, I suspect. So, you're familiar with this. This is the quality of evidence that we look for at NICE when we're judging the quality of evidence in trials. And right at the top of the pyramid, we have a thing called a systematic review, which, with or without a meta-analysis, where we look at lots and lots and lots of randomised control trials are very high quality. And we say, what do we conclude from these? I mean, diabetes is a very good one. We now have lots of RCTs on diabetes where we know what the best treatments are. Yeah? Then down to randomised trials where I'll say, right, you three and you three, you're going to have the treatment, you're not. But you two, you're not going to know which group has had the treatment. I mean, you were just going to see what happens at the end of it. You know, the allocation is completely random. You've all got a diagnosis of autism, that's all it is. And I'm going to put you in group A and you in group B. I could be really fancy and cross you over, cross the treatment over halfway through to confuse you further. But that's about the level of it. These are groups which are usually 3 or 4 or 5 or 6. Diabetes trials, you're talking about 10,000, 15,000 drug trials, things like that. You know, so the quality is pretty poor. Because the other thing that happens is I want this treatment to work. So I'm biased. You know, I'm biased. so I'm probably going to drop some hints as to who's had the treatment and who hasn't. And I want to see improvements, probably where there aren't any. So then down through case control studies, again you can get lots of information about individuals, record before after measures. Cohort studies, again you might have a group of children going through a particular program and you're assessing the program on this group of children overall. Case series, that is lots of individuals all linked up having the same treatment but they're not part of a randomised trial. And then case study, that is one person, one intervention, before and after measures, the usual thing. Where do you think most of the evidence is in autism? And then opinion, people, you know, like me just saying that's great or that's rubbish. Where do you think most of it is in autism? Where on this hierarchy, where on this pyramid?
At the bottom. Case studies.
Most of it is in the bottom 2 tiers. And it gets worse the further up you go. There are virtually no systematic reviews. So again, it's just not my opinion. This is what the guys from NICE have produced based on what they call grade evidence. That is what you would normally expect to see before you make recommendations for treatment. Would you fly in an aeroplane that had that quality of evidence that, you know, would you have an operation from a surgeon where he was basing his practice right at the bottom? Well, you might if you got something very rare, but generally speaking you wouldn't. So there's a strong case to be made for improving the quality of evidence. Having said that, I'm going to go a little bit further on this. You familiar with this gentleman? You will be. You know Krusty?
Yeah.
Yes, absolutely. We met him personally outside of Athens. Oop, what's happening there? But Krusty was an innkeeper, and he also probably had obsessive compulsive disorder. But if you visited his inn, you had to fit his bed exactly. And if you were too short for the bed, then he would stretch you. And Krusty means the stretcher, the stretch you. If you were too long, he'd chop your feet off. And that is a model of service. That's the model for services for autism generally in this country, for children and for adults. You have a treatment, and you fit the child into the treatment. You have a service for adult, you fit the adult into the... I think the advent of personalisation is about to change all of that, I would hope. I think we've got a good chance now. You know, if we really work in a personalised way to put Procrustes out of business. Actually, he went out of business anyway because he was captured by somebody whose name I can't remember, and he was subjected to the same fate. Chopped his feet off. And as Lorna said, you know, the treatments vary depending on the belief system of the therapist involved. So, there are lots of difficulties in evaluating treatments. People get better anyway, they change. We all change as we get older. Getting control groups is very difficult, so we shouldn't really bother too much about that. But we should at least attempt properly controlled trials. That is, we know what we're doing to people. We recognise bias in everything. That is, bias, investigator bias, parent bias, dissonance. They spent £50,000, they want to see an improvement. The reality of family life, you know, they don't want people like me sitting in a clipboard in the living room. You know, it's recording results. So, you know, it's a very difficult thing to arrange. Several approaches used at the same time, and some of the methods, the randomised control trials, might not actually be terribly fit for purpose at the end of the day. You know, you might think, well, with such a heterogeneous condition as autism, is a randomised control trial the best one? I think usually the answer is yes, but there might be occasions when it isn't. Again, we've talked about diversity. We're not terribly good at describing what autism is from a treatment perspective, and we're not very good at deciding what it's going to do either. That's the other problem. I mentioned the fidelity. Most of the claims are anecdotal, that is, stories that parents will tell you or the therapist will tell you about their treatment, and very little agreement in terms of priorities. What should we actually be focusing on first? Two ways of looking at this: evidence-supported treatment, or ESC. This is EST. This is very dry stuff in a sense, but it starts with the treatment. So you might say jelly baby therapy. I'm going to give you all jelly baby therapy. I've got a big box of jelly babies here, and you're all going to come, and you're going to have a jelly baby every day for the next 6 weeks. And at the end of it, I'm going to see what's happened to you. Okay? That's one way of doing it. So I'm starting with the treatment, and that's evidence, what they call evidence-supported treatment. Evidence-based practice, on the other hand, is I might say, well, actually, you look as if you could deal with, you look as if you need a jelly baby, but you don't. No, jelly baby's not for you. But for you, I'd like to give you a jelly baby every day for the next 6 weeks and see the effect on you of that. But I'll also be looking at you as well, and I'll decide, you might not like jelly babies, but lollipops are your thing, you see. So after a week or so, I might say, well, I'm going to start giving you a lollipop to see what happens to you. So I will have a slightly different view of your treatment than I would of yours. So I'm starting with you because I recognise that you're a jelly baby. You're likely to respond to jelly babies and you're not. So I'm differentiating at the point of treatment. And so often that doesn't happen. Everybody gets swamped into the same, put into the same treatment module, whether or not we've decided it's a good thing for them or other. And you can then try lots of other things, because I might start you off on jelly babies, and after a little bit I might say, well, actually, I think you probably need to have extra jelly babies, and probably a Toblerone as well every week, and we'll see how whether that measures up to anything. You know. So we can begin to fine-tune the approach to the individual child, and that's when we talk about evidence-supported treatment and evidence-based practice. I think these are the sort of key differences. The organisation I work for, this is not a commercial, it's just if you want to make a note of the website, we're going now for 9 years, well it'll be 10 years His website was 9 years, the organisation's 10. Trying to get trusted information out there to people, you know, and then right from very basic information through to the more detailed stuff. And this is more or less what we found, that in terms of biomedical treatments and the complementary treatments, there's some limited evidence, but only if you've got a specific syndrome like PKU, phenylketonuria. Do you know what that is? It's a metabolic genetic disorder which, if untreated, can cause autism. And if you diagnose it, I mean, all of you will have had the test shortly after birth for PKU. It means that you can't metabolize phenylalanine, which becomes toxic to the brain. But it's very easily fixed with a diet which is free of phenylalanine. It's quite rare. But you do see some children these days in different parts of the world where they don't do these tests with autism, which is a result of this particular metabolic disorder. So that is the only one that we know of where you can say, yes, there is a definite treatment for this, which is there may be others that we haven't yet identified, and that's why some of the genetics work is very important. Psychoeducational stuff, structured behavioural interventions, we know about these things, they can be quite good, especially visual ones. Drugs, mixed evidence, but lots of hazards. Risperidone is probably one of the most commonly used drugs, not licensed for children, which is used in children. And with very nasty side effects, including weight gain, lots of gynae problems associated with it for girls, you know. So it really is a very toxic, nasty drug, but it's very commonly used in autism to control anxiety. But the randomised trials give you a very mixed picture. Psychotherapy, there's some mixed evidence on that, and creeping into some of these things, and it's not quite clear where some of these things fit, the more modern forms of cognitive behaviour therapy, some of these sensory interventions, we're not quite sure where to place them. But they do seem to be quite helpful for some people. Now, where there's good stories, but little or no evidence are around diets and these kind of things, you know, the options, touch therapies, all this kind of stuff. And you can see why some of these things might work. I've just finished a trial looking at the effectiveness of pet dogs in the family. The PAWS project, with dogs for the disabled at Lincoln University, showing that actually having a dog in the family reduces parenting stress. And the next phase is to see whether it reduces stress in children. I think it does. I think there could be an oxytocin link as well there, we don't really know. But, you know, some of these things, there's very little evidence at the moment. We do little studies, proof of concept, so we can go to the National Institute for Health Research for big money further down the line. All of these things, and some of these are ancient history now. They don't use them. You know, they tend not to. They've fallen out of. But although you go to some parts of the world, I was talking to colleagues in Greece a couple of weeks ago, and saying that some of the treatments that are in vogue in Greece, we wouldn't use these days. There are laws against it, in fact. So this is the way that, you know, different licensing and different pharmacological rules apply. You can't actually prescribe some of these drugs to autistic people, whereas in different parts of the world who don't have the same protocols, I'm not saying they're worse, but they don't have the same protocols, then these things still happen. So all of this kind of stuff going on. Oops. There have been reasonable studies done in all of these areas, vitamin B and DMG and all these kind of things, and they've found to be ineffective. So these interventions do not work on the basis of trials. They're not particularly harmful, but they don't work. They don't do any harm, but they don't work. Then we've got another group which is ineffective and harmful. Facilitated communication being top of the list. There are lots of studies done on this now which shows that facilitated communication doesn't work. But that's not to be confused with augmented communication. Auditory integration therapy and intravenous immune globulin. These things do not work, and there are good studies to show they don't work, and they're hazardous. But again, in certain parts of the United States, these things are all widely used. And I suspect in other parts of the world as well. In France, they just give people psychotherapy. Now, limited testing, some promising but inconclusive results. This list here: teach, thou, social stories, CBT, assistance dogs, mentoring, and so on. Some specific psychotropics, oxytocin. Jury's out on oxytocin. It's the bonding hormone, the love hormone, oxytocin. So you give it a nasal spray and you feel all loved up for a minute, and it disappears. That's an interesting story. Intensive interaction, Phoebe Caldwell's method, dealing with people who are non-verbal, very effective. Some wonderful anecdotes, promising, but no trials. And you wonder how much of it is Phoebe and how much of it is the method. It's really hard to untangle. And those things with little testing and some concerns. Chelation therapy, very dangerous, heavy duty method. Androgens, that is chemical castration, been used quite a lot in the United States with children, autistic children, based on a flawed theory of raised fetal testosterone. Simon Baron-Cohen's group at Cambridge did a lot of studies showing that raised fetal testosterone in autistic children was an issue for some of the children they tested. They've gone back a little bit on that now. But to Simon's horror, this group in the United States started treating children with these very powerful drugs. Hyperbaric oxygen in these chambers, the diving decompression chambers. ECT, again in some parts of the world, not so much here now. Oral organ extracts, stem cells, all this kind of stuff. These are all very commonly in use. Then these are things with more evidence to support them. Functional analysis, these communication-based interventions, behavioural approaches, and intensive ABA in children. Although, having said that, there have been very few follow-up studies of these children. They do seem to show gains in IQ when they're very young, but they're not followed up. We don't know what happens to them later. And it might be that there are other things which are just as effective with that group of children. We don't really know. Patricia Howling's list. I won't go through these because we're virtually out of time, but these are all the things that really underpin the SPELL framework we're going to be talking about later. So some evidence then. If you can target particular things that you want to work on an individual basis with children, then you're much more likely to be successful. Trying to help them to improve language communication does seem to bear fruit. And the earlier you can do that, clearly the better, because it's going to head off a lot of the other issues. The strongest evidence from a research point of view is for these early intensive behavioural interventions, but there is a health warning that goes with that. We don't know about it later, and we now have autistic adults telling us that they were traumatised as a result of some of these treatments that they had as children. Very few controls. We talked about these issues, yes. And Eric Schoppler from Division Teach told me once, he said that he would like to see more studies done on adolescents, because in his experience, that's when these young people turn from very confused, angry, frustrated into sorted. And what happens to them? So it's not the very early years where he sees most of the change. It's through adolescence into adulthood. And a message of hope for parents, I think, is things do get better. And your young person will be very different when they're in their 20s to what they are now, especially if they get support to be self-confident, support to be able to communicate, and we recognise their differences in a way which is positive acceptance. Symptoms may respond by saying no evidence. Once autistic, always autistic would seem to be the mantra. There's no evidence that, apart from specific biological syndromes, that you can actually change the core condition of autism. Again, no drugs that they seem to be using. And we do know a bit more now about genes, not a lot. There's a lot of money devoted to genetic research. We're beginning to make some associations, but not in terms of helping us in a treatment context at present. The neurobiology of autism is interesting, but that's all it is at the moment, is interesting. Again, there's no evidence that you can interfere with that neurobiology, and the whole science of neuroscience is very, very young. So again, things are being changed about our understanding of neuroscience on an almost daily basis. If you read the neuroscience journals, and particularly the letters columns, you will see the level of disagreement between people who are world experts over very fundamental principles of neuroscience. It shows you, that we're a long way from this being a done deal. So, to conclude then, so there's very limited evidence for cure or recovery. We need to be clearer about what we're doing, better evaluation of studies, and make better use of what we do know already and what we don't know already. Make better use of that too. And if something is promising, then we need to adopt a discipline, a research discipline for looking at it, rather than just get carried away on the latest flavour of the month. So, going back to the key questions then, it's a vexed question: is autism? There's no evidence from published studies that autism is curable. Is it preventable? Some evidence that, say with PKU, that you can prevent the development of autism if you intervene, but it's only one. Jury's out on toxins, pollutants. Is it treatable? Limited evidence that core features are susceptible. The autism-friendly environment seems to make a big difference, and other conditions associated with autism are definitely treatable. And as for the best treatments, well, it's as simple as this: those which are suited to this individual. I couldn't tell you a best treatment for autism, I wouldn't know. I'd have to wait to see the person, it's the old thing, if in doubt, see the patient. So I think that's about it. Yes, and Thomas Galtieri, again, one must disenthrall oneself from the idea that one is dealing with a unitary disorder. There is only the person with unique and highly individual human needs. And Galtieri wrote that in the 1980s. Shows Back to the Future. And just to thank some of my colleagues, and we've overrun by 5 minutes. But we can pick up questions later, because I think we've got quite a decent chunk of time for the next session. Well, I was told I had to get through that, okay? So I hope thank you for bearing with me. I hope the lack of interruptions were not that you were totally bored or nonplussed or furious. But if you were any of those things, then we can pick it up. We can pick it up after the break, and we resume at 11. Is that okay with you? Do you need longer than that, or is that about right? Okay, thank you very much. Oh yes, if you need to ignore that email, I'll write another email on there, because that's no. I'll still pick that up. You'll get it.